Thank you for joining us on Coffee Break, brought to you by the Middle Alabama Area Agency on Aging, or M4A. M4A is a part of a network of 13 area agencies on aging that cover all 67 counties across the state. We are located in Alabaster, and we cover Blount, Chilton, Shelby, St. Clair, and Walker counties. We would love to find out how we can help your family today. For previous episodes of Coffee Break, feel free to check out our YouTube channel. All right, it looks like we've got a pretty good little group in here, so we'll go ahead and kick things off. And again, if you're joining us late, we do record these coffee break sessions, so feel free to refer back to them if for some reason you may have caught the tail end of this presentation. We will be recording this live, like I mentioned, and we also have this running on our Facebook live stream. So for those of you that are in our Facebook world, make sure to drop any comments or questions in the comment section. We monitor those as we go, as well as here on the Zoom platform, we also have a chat feature and a Q&A window. So make sure you drop any questions, regardless of, if that's during the middle of the presentation, feel free to drop those in. We'll have time towards the end to do a Q&A session to make sure that those questions get answered for you. So for those of you who are joining us for the first time, we've been doing this initiative called Coffee Break since the pandemic really kicked off last year. I think our first coffee break session was towards the end of March, early April. So we've been doing these for quite a while. We originally started these as a twice a month initiative, but we've cut it back to just once a month, which is the last Wednesday of every month from 1 to 2, unless there's, some type of event, holiday, or something that we need to kind of coordinate around. But for the most part, we try to do these every Wednesday, or the last Wednesday of every month, rather, from 1 p.m. to 2 p.m. Today is session 24, and we're going to be going over oral health. This is an in-house program that our agency, specifically two of our in-house programs, the PANDA Project, our Alabama Cares Caregiver Support Program, have kind of teamed up on to bring, educational topics. Some topics are more serious than others. We've ranged from gardening to food to today we're covering oral health, as you see there on the left. So we've really tried to keep it, changing a new topic every month to keep it interesting. And really the ideal goal here is to provide family caregivers with a brief respite moment to also have something educational that they can learn to help ease their role as a family caregiver. So for those of you who have joined us who are not caregivers, we don't mind. We always welcome guests. So feel free to hang around with us, because I'm sure you'll grab something that's going to be helpful for each of us. So be sure to stick around. Today we have oral health, and that is we have some special guests from UAB's School of Dentistry. We'll pass it along here to show who those two speakers are. We've got Dr. Nathan Smith and Dr. Raquel Mazer, and they're representing the UAB School of Dentistry. And I'm going to pass it on over to them to get things kicked off for us as we cover oral health in our July edition of Coffee Break. So I'm going to stop sharing my screen now, Dr. Smith, and let you take it over.
All right. Good afternoon, everyone. Hi, my name is Nathan Smith, and I am with the UAB School of Dentistry. And I am thrilled to be here today. I'm excited to have this time to talk with you about our oral health and how that's related to overall health. Thank you to everyone who's watching, and thank you to M4A for inviting us here today to speak. I hope that this information can be interesting and useful in your day-to-day activities, whether you're a caregiver or a healthcare provider or anyone else who's interested in this topic. So oral systemic health is the connection between oral health and overall health. Countless studies have demonstrated a link between poor oral health and systemic disease such as heart disease, diabetes, stroke, dementia, arthritis, and even pregnancy outcomes. All right, so today I'll be reviewing general demographics of older adult population. So unless otherwise mentioned, this group is usually we're referring to people over the age of 65. Then we'll move on in our discussion to conditions that are more common in this age group. Then we'll go over the next portion, which is where my colleague, Dr. Raquel Mazer, will take over, and she'll be showing some common diseases of the mouth and teeth and the importance of regular dental visits. We've saved time at the end of today's coffee session to go over questions and answers that you may have. So when we say older adult, who are we talking about? How many people make up this population group? And what are some general characteristics among this group? I promise the entire presentation will not be numbers, but just to give you a general idea of how many people make up this population, I have included a lot of numbers and statistics in these first few slides. I think that it's important to understand that this population is growing and that it makes up a significant portion of the overall population. The population of people over the age of 65 is growing not only in our own area, but across the world. The main drivers of population aging are fertility decline and mortality decline. So as you can see, over the 10 years between 2008 and 2018, there was a 35% increase in the portion this population makes up. So that's about 1 out of 6 people in America who are over the age of 65. And nearly 1 out of 10 of those people were financially below the federal poverty level. And from this slide, you can see these percentages are similar in Alabama as compared to the nation. So a little more on population growth. Over the past 10 years, the population of people over the age of 65 increased from nearly 40 million to over 50 million. So that was a 35% increase in just that short amount of time. And it's projected to be over 94 million people by the year 2060. There were also over almost 100,000 persons over the age of 100 in 2018. And that number has nearly tripled since 1980. This graph provides a visual of how many people over the next 40 years, like what will the population look like? The portion of the population that are over 65 will make up a larger portion of the US population than ever before. So where are all of these people living? Well, most of them are aging in place. That is, they're staying in their homes for as long as they are physically able to do so. Of the older adults living in the community, more than half of persons over the age 65 lived with their spouse or partner. Almost 1/3 of all older adults living in the community lived alone. The portion living alone increases with advanced age for both men and women. Among women age 65 and older, for example, 44% lived alone. A relatively small number of people over the age of 65 lived in nursing homes in 2018. However, this percentage increases dramatically with age, ranging from 1% all the way to 7% when you look at the 85 plus group. Most older Americans live independently in traditional communities. Others live in licensed long-term care facilities, and others live in communities with access to various services through their place of residence. Such services may include meal preparation, laundry, cleaning services, and help with medications. In 2017, about 2% of the Medicare population, age 65 and over, resided in community housing with at least one service available. About 3% resided in long-term care facilities, and nearly all of them resided in traditional community settings. The percentage of people residing in community housing with services and long-term care facilities was higher for the older age groups. So what about insurance coverage? Less than 1/3 of people age 65 and over reported having dental insurance in 2018. The percentage with dental insurance declines with age, all the way to 21% among the age group 85 and over. About 2 out of 3 people over the age 65 had a dental visit in the past year. And the prevalence of edentulation, that's not having any of your natural teeth remaining, was about twice as high among people aged 85 and over as compared to the 65 to 74-year-old group. We know that people are living longer and that they're keeping their teeth longer than in past generations. If we look at the number of people who are edentulous or who have lost all of their natural teeth from the early 2000s compared to more recent years, there was a more than 30% decrease in the number of people who've lost all of their natural teeth. So this is good news. Now let's move on and talk a little bit about the health conditions that can be more common as we increase in age. The risk of chronic diseases increases with age. Chronic conditions usually require ongoing medical care and are major contributors to the healthcare cost. The majority of older adults have multiple chronic conditions, which contribute to frailty and disability. Many of the negative side effects of chronic conditions are caused by health risk behaviors that can be changed and that are preventable. Here you can see some of the most common chronic diseases affecting this population. Hypertension or high blood pressure and arthritis, both of which affect over half of this group. Heart disease, cancer, and diabetes affect about 1/3 to 1/4 of this population. Stroke, asthma, and COPD are also common chronic conditions. Of these common chronic conditions, asthma and arthritis were more common among women. Increasing in age is associated with physical and sensory limitations. Arthritis and decreases in muscle mass or muscle control can make it more difficult to perform routine activities. For example, moving your mouth. Your mouth is used for speech, chewing, and swallowing. So these can all become more difficult when you lose muscle control. We use our hands to brush our teeth. So people with arthritis may have difficulty holding a toothbrush or completing the movements required to complete mouth care. Getting in and out of a chair, general mobility, how easy it is to leave your house. These are all things to keep in mind. There are also sensory limitations associated with aging. We use our senses of taste, and possibly even more useful is the sense of smell when deciding when a food is appetizing. Aging is associated with a decline in our ability to taste and smell. What do we do when something doesn't taste good? We tend to add salt or sugar to that food, which is not the healthiest addition when considering chronic conditions such as hypertension or high blood pressure, diabetes, or dental health. Also keep in mind a side effect of many medications is altered taste. Another example of change in our bodies that occurs with aging is joint pain. This can lead to difficulty with motor function. It's more difficult to complete routine brushing and flossing when your fingers either will not move the way they did when you were younger, or when you're experiencing chronic joint pain, making you dread the idea of trying to hold a toothbrush or to manipulate floss. As we age, we may experience cognitive limitations. Examples include dementia, Alzheimer's disease, and memory loss. Changes in our brain may make it difficult to control muscles. Having poor muscle control can affect the muscles around our mouth, which can make it more difficult to speak and to eat while wearing dentures. These limitations have been shown to put a person at increased risk for diseases of your mouth and teeth, including caries, which is commonly called tooth decay, periodontal disease, commonly referred to as gum disease, and other oral infections. Tooth loss, dentures, and decreased saliva can lead to altered diet. Elders may experience the following: changes in the way that we feel and taste our food, decreased chewing efficiency. That goes back to the decreases in muscle mass or poor muscle control. These issues can decrease the intake of nutrient-rich foods. So we may eat less fruit and vegetables, which usually have more fiber content and also have more vitamin C and beta carotene. To balance out these changes, people may adjust by keeping mints in their mouth or consuming sweetened beverages to mitigate dry mouth, which may result in empty calories or increased risk for tooth decay. Very quickly, I wanted to mention a little bit about medications. 39% of the people over the age of 65 reported using 5 or more prescription medications in the past 30 days. 90% of this group reported using any prescription medication. An also interesting statistic is that every average older adult takes several medications, and on average, 2 to 3 over-the-counter medications and 4 to 5 prescription medications. Many of the medications, both prescription and over-the-counter, can negatively affect the amount of saliva someone produces, as well as the quality of saliva that we have. These negative effects are additive when someone is taking many medications with this side effect. As we age, our organs decrease in function. In other words, they essentially slow down and are not able to do their job as efficiently as they once did. The overall impact of age-related changes is a longer duration of the drug's effect and its potency. We could have an entire talk just about the issues and concerns related to medications and oral health. So we may need to come back in the future to talk about this more. Okay, now I'm going to turn the presentation over to my colleague, Dr. Mazur. She has some really interesting slides and some good things in store for you.
Let me make sure I unmute myself. Can everybody hear me? Just making sure. I'm glad to be here this afternoon, and I know Dr. Smith has thanked on our behalf for the opportunity to speak and to have some content for those who are so involved in care, in facilitating, and also advising, monitoring some of those individuals who need assistance in our community. So I hope this is of assistance to everyone as a group. And as mentioned, we'll be glad to add content as time permits and bring a little bit more to you all, maybe even in a future session, and answer some questions towards the end. So many times and this is kind of unfortunate, Dr. Smith is mentioning how much of a connection there is between what happens in the mouth and what can happen in the body. And it goes both ways. We can have diseases of the mouth that can affect the body, and we can have diseases or ailments of the body that can affect the mouth, or treatments for diseases that can affect the mouth. Many times the mouth goes ignored, and we don't like to think that way, but it is a fact. There may be an individual that we're helping and tending to that has severe heart problems, severe respiratory problems like lung, breathing issues, diabetes, and we may not be attuned to what's going on in the mouth until we wait for symptoms. And if I don't leave any message here, I would love to make sure that I leave everyone with a message that if we wait for symptoms to occur, it's usually kind of late. So we want to be vigilant. We want to be proactive about trying to take care of oral issues, dental issues, because they actually contribute to a quality of life in any individual of any age group. For example, we know that children miss more school because of dental problems than many other medical conditions. And we know that there are several adults, and senior adults included, that have quality of life issues related to lack of oral care, lack of attention to dental problems, mouth pain, discomfort in the mouth or the oral cavity. So what I would like to do here today is make sure that we touch upon some of these common issues. There are some things that change naturally, and there are things that change just because they're a function of disease or pathology. So what are some of the things that happen kind of like physiologically? It happens to any individual who lives long enough to be around and retain his or her teeth. We do experience some degree of wear of the teeth. We use the teeth, there's enamel that covers that tooth or the groups of teeth. And if we use our teeth as a group and we have many teeth in the mouth like we're designed to have, that wear is only a moderate to minor wear. When we start losing teeth, or if we lose teeth that are not replaced, we start seeing what we call accelerated wear or loss of that enamel, which then predisposes that patient or that person to more problems. We also have changes in shade. Before the meeting started this afternoon, we were talking about coffee and how I enjoy my coffee. So there are certain things in the foods that we ingest. There are certain chemicals, some of the natural ingredients that have a chance to change shade or coloration of the teeth. And this is kind of something that we expect to see. And there are some who want the shades changed back to a bright color and whitening the teeth, but that's something that we do more as not a necessity, but something more cosmetic. Sometimes we see loss of form or loss of shape of the teeth. And I will give you one example where the form and the loss of enamel come together. For people who have a lot of stomach problems, for example, a lot of acidity in the stomach, people who have gastric reflux, or indigestion, that's chronic indigestion that is not treated properly, then that can affect the teeth. And you may say, well, that is in my stomach. Why would it affect the teeth? Because when we have that high level or constant level of indigestion, then that indigestion or that acidic content from the stomach may actually come back to the mouth, and it causes problems for the esophagus or the tube that takes the food down, and also for the teeth. So we have some wear or loss of the enamel that's really not natural, it's really not normal, but it's now linked to a medical problem. We can also see fractures of the teeth, and fractures tend to appear when we do things with our teeth that are not meant to be, our teeth are not designed or meant to be doing. If we use our teeth for something that's not proper, opening things and tearing things, and Dr. Smith just mentioned that, you know, our aging population may lose its ability to use the hands properly. So utilizing the teeth to assist with that may not be the smart thing to do. We may see fractures of the teeth when the enamel or the teeth are being used for something other than normal chewing. We also see fractures and severe wear of the teeth for folks or individuals who grind and clench. And the grinding and the clenching is not something that is normal for us, especially if that occurs throughout the hours of the night or many hours during the day. If that happens, for example, if that individual has some neurologic problems or neurologic deficits, sometimes we see that with individuals who develop Parkinson's disease. This is just to illustrate. It's not to say everyone who has Parkinson's will have that, and not every individual with dementia will have that. There are some medications that can actually cause bruxing and grinding of the teeth in excessive ways. Something that we see commonly that's a change on the teeth is the root exposure, you know, the gum receding and the root being exposed. This is a common occurrence. We see that in individuals of different ages, and we need to be attentive to that because root exposure can cause the teeth to be more prone to decay, more prone to sensitivity, and more prone to problems on those surfaces. We also see a change in sensation on the teeth. For example, our patients who might be 18, 19, and 20 have more of a sensation, for example, to cold and heat on their teeth. And as we age, there is a change in temperature perception even with the teeth. So some of these sensation changes might be considered physiologic, but we kind of look at those changes in context. We need to see if those changes are normal or evaluate and assess the patient to see if those changes are actually linked to a problem, to an abscess, an infection, or something more severe happening with the tooth. The other thing that we know that changes with time, the other portion of the mouth, the other part of this organ that's the oral cavity, is the gingiva, or what most people refer to as the gums. We have a tendency to have changes in quantity of that gum tissue, how tall it is, how much it wraps around the teeth, also the quality of it. Just as we see many times as humans age that the skin gets more frail, well, the gum tissue can get more frail. There could be presence of inflammation or redness or irritation on the gums that may be more prevalent in certain age groups, or even more prevalent because of other problems or other issues that may cause dryness or may cause rubbing of prosthetics, like a denture that is not well fitted in the mouth. So the gums are also affected, whether it's something physiologic and normally occurring, or if there is a disease process. Individuals who have inflammatory diseases, or what we refer to as autoimmune diseases, they undergo a lot of changes. They see a lot of changes and a lot of transformation in their gum tissues as well. And of course, the use of prosthetics, you know, the partials, the dentures, something that may rub against that tissue, that can cause changes, and it can also cause discomfort. What we refer to as the mucosal tissue is something that's not the teeth, not the gums, but, you know, the inside of your cheeks, the inside of the lip, right around the lip area. All of these areas can be affected. They can get thinner. The mucosa can get thinner and also more frail with time. They're also easily affected by chemicals. So what we see commonly is that when someone perceives a problem, our immediate instinct is to try and solve that problem on our own. Let's see what we have, they'll take care of it. I have something going on with my mouth, so I might use some mouthwash before I go in to see the dentist, before I ask for help. I may not have good breath. So instead of going to check where that is coming from, I may try and use some mouthwash or gargle with peroxide or do something else. So remember that the mucosal tissue can be affected by different chemicals and different products that we use in the mouth, including alcohol. Alcohol from ingesting a beverage that contains the alcohol, and also products that may contain alcohol. So it is important to be attuned to the whole system before we actually see where a problem or discomfort might be coming from. Another aspect of the mouth that can be easily affected is the bone. Our teeth are supported by the gum tissue and the bone that's underneath it. And there are little fibers that actually hold the roots of the teeth in place. So individuals who have bone loss, generalized bone loss, maybe due to bone density problems, osteoporosis, osteopenia. We know that there is a large occurrence, common occurrence of those problems, especially as we get less mobile and individuals may get more fragile. There is a tendency to lose bone, and we do not lose bone only in our backs or hips or legs and arms. We lose bone in every part of our body where there's bone tissue, including the bones in the jaw. So we have an upper and lower jaw that will retain and hold the teeth in place, and there's potential for bone loss around the teeth. That bone loss can be physiologic, just because some of it is lost over time, but it can be linked to pathology or disease, such as just mentioned, osteoporosis. It can also be linked to gum disease. And we'll talk a little bit more about gum disease in just a minute. So what are some of these changes that we see with aging? This is a beautiful mouth here, you know, a 20-something, 30-something-year-old could get to a 40-something-year-old that would look just like this. Beautiful teeth, nicely aligned, great shape, great shade, great shape, great form to the teeth. Then as we age, we start obviously maybe needing some restorations or fillings and things that need to be to preserve and to restore the teeth so we can retain the teeth. And we know that our adults are preserving their dentition a whole lot longer than they did 30, 40, and 50 years ago. In fact, the baby boomers are the generation retaining natural dentition longer than any other group preceding them. So there is a great value to that. Retaining dentition, retaining the natural teeth improves the quality of life. You can eat better foods with your natural teeth, but it also means we have to be attentive to them. We need to preserve the teeth, maintain them, keep them healthy. So these are some changes here. In this slide, we see, for example, that there is a little bit of wear on these incisal edges or biting edges of the teeth, a little staining here from an existing filling. This is not major. It's not like there's obvious decay here in this particular picture. But remember, we don't just detect things by giving one quick look. On the far right, what we see is that there's a whole lot more wear or abrasion of the enamel that has happened over time. So these are some common examples of what changes over time. Changes, for example, on the lower left, we see little chips and wear of the teeth. We see changes in the color of the teeth and the coloration of the teeth. And some of these issues can be addressed with early interventions. Some of them may be minor that don't need any addressing, don't need any correction or treatment. And some may benefit even from preventive strategies or disease halting strategies as well. And on the far right, we see a dentition that has really changed over time. And what we see here is we see wear of the teeth. We see what we call erosion of the teeth, where that enamel is really wearing on different surfaces and different sides of this mouth here, both on the outside where we look straight on to the enamel. There is staining in a lot of areas. There might be cavities here. We can't really assess everything just from looking at this snapshot. But just to give you an idea of some of the changes that can occur and may occur over time. So one of the disease entities that we know that can affect a lot of adults, and a lot of adults of any age, but especially older adults, is what we call periodontitis, periodontal disease, or gum disease. And, you know, we may watch TV and listen to a show on the radio, on the internet, and somebody will be talking about gum disease, you know, see your dentist about gum disease, you know, prevent it this way, use this toothpaste, and so on and so forth. And yes, it's very important for us to brush and to floss, but it's also very important to be checked. And if there is a diagnosis of periodontal disease or periodontitis, that intervention and treatment takes place. In the older adult segment, almost 70% of this population has some form of periodontal disease or periodontitis. And this is significant because it is a high percentage. And not only that, we don't treat periodontal disease by just staying at home. So many forms of periodontal disease require the intervention of the dentist and the hygienist before a patient can actually maintain health and keep that disease from progressing. We also know that among our older adults, we have what we call untreated decay. Not just the fact that they've had fillings over time and they've had crowns or caps and other restorative treatments, but there's actually untreated disease. And this here becomes a problem because it's a source for infection, it's a source for pain, it's a source for bacteria to grow and to have a niche in the oral cavity, actually creating problems and maybe inducing some forms of pneumonia in the older adults. So it is important to have dentition or the teeth checked. We also know that older adults experience tooth loss, unfortunately. I would like to leave everyone with the notion that every tooth is important in the oral cavity, and to say, well, you know, I'm 60, I'm 70, I'm 80, I don't need my teeth. We all need our teeth at any age and at any stage of our lives. So it's really important to prevent tooth loss. And if we have gum disease that's untreated or decay that's left untreated, it will contribute to that event of tooth loss, and many times without the need for it. Now, there are tooth losses that are unfortunate. You know, someone may take a fall and hit the teeth, and they're severely broken to the point that we can't restore, we can't maintain them. But that's the unfortunate accidental event. We would like to treat diseases of the mouth to make sure that we can prevent tooth loss and we can prevent infection and disease spreading to a systemic type of appearance or presentation. Another disease of the mouth that many times goes unnoticed is oral cancer. And this is kind of unfortunate because, you know, we can treat periodontitis and we have a lot of measures to treat periodontitis at different stages. But with oral cancers, depending on how the disease presents and how aggressive that lesion might be, it becomes very difficult. It may become very disfiguring. It may become very harsh and very difficult to treat patients with different types of oral cancers. And the median age for diagnosis of oral cancer is 63 years of age. So there is a significant presentation of different types of oral cancers in this particular age group. Very, very important to evaluate the patient as a whole, ask the pertinent questions, check to see if there is a history of habits and other contributors to the presence of cancer. So it is important not only to have a medical checkup, but having a dental checkup. And also other chronic diseases that affect the mouth, what we refer to as polypharmacy. We have a large segment of the population in the United States in the adult groups. And when we go to older adults, the presence or the prevalence of polypharmacy is really significant. individuals taking multiple medications. They're taking multiple medications to control systemic diseases, to control medical problems. And what ends up happening is that some of these medications may affect the mouth. So does that mean that we're going to remove these medications and tell them to quit taking meds? No. What we need to do is to work with the patient, work with that individual, work with the physician, and work with the caretakers to see what we can do to improve this, and to also check the mouth, and even prescribe some products, and even some over-the-counter meds even to diminish symptoms and the repercussions in the mouth. Xerostomia being one of the major consequences of multiple medication intake. So going back a little bit, we talked about periodontal disease or gum disease. And when speaking about caries, caries is that disease that will forever exist and we will be forever prone and predisposed to as long as we have teeth. Unless we don't have our teeth, we're not predisposed to decay or caries. I have teeth in my mouth. Dr. Smith has teeth in his mouth. Sorry, Dr. Smith. But we are all predisposed to decay. I'm predisposed to caries. If something happens to me and I have a dry mouth all the time, or I break my hand and I can't clean and floss my teeth, I've got to come up with a measure to fight the predisposition or the propensity for developing decay. So each one of us is predisposed to decay at different stages of our lives, and with a different degree of severity, depending on what we're doing, how we're eating, how we're drinking, how we're taking care of them. On the slide on the left, we see a presentation of decay or caries at what we call the cervical part of the tooth, which is the part of the tooth that's very close to the gum line. And it's a part of the tooth that actually tends to collect a lot of the plaque and the food debris. So many times we will work with patients and caretakers about how to best clean, how to best debride these areas so we don't have this kind of presentation. On the far right, what we see here is someone who has aggressive type of decay and a presentation of decay that is really detrimental to this person's teeth and also to health. And we'd like not to see this, but it's still a significant occurrence in some populations. And there's another type of caries or decay that we don't visualize so easily. And that's the type of decay that is usually present in between the teeth. And that is what we see here, that we can only detect this type of decay when we do a proper examination and we take x-rays. And that's what you see here on the lower left side. After taking x-rays of the teeth, we're now able to visualize if there are areas that we can't inspect by just looking at the teeth, but that we need to check, for example, for areas like these, where we have decay actually invading that tooth and actually getting very close to the nerve. And I don't mean to be so specific and so technical, but I'm hoping to leave you with the message that having someone with the proper knowledge inspect and actually advise on the care of the teeth is very important. It is common that we will see the presentation that you see on this slide here of a patient on the left that has some wear of the teeth, some loss of the enamel, and some loss of the dentin, and also loss of the teeth. These are natural teeth that are worn because this patient actually didn't have any teeth in the back, and without having the teeth in the back, couldn't chew properly and started using the front teeth to chew, because we're going to eat and it's something that we need to survive. And what happens when we lose the teeth, we lose the ability to distribute the forces and chew with all our teeth. And on the right-hand side, we see someone who has lost all of their teeth. And if we don't replace the teeth, this person will really be debilitated, and the nutrition will be compromised, therefore compromising the health for this individual. We know how important it is to have protein intake at every stage of our lives. And it's definitely critical that we make sure that our older adults have proper protein intake, because we tend to lose muscle mass with time. So what we see here is the patient on the left, for example, received some caps to restore the teeth and rebuild the teeth, and we placed a partial denture to replace the teeth that were missing to help this patient have a full rehabilitation of the teeth and better chewing. And what we see for the patient on the far right side is that a set of dentures was made. These are some false teeth. They look beautiful. They don't replace our natural teeth the same way, but they are a viable replacement when someone is missing all of their natural teeth. So we also know that tooth decay in elderly groups or older adults is something that we have to be very attuned to. There are different parts of the tooth that can be affected by decay. What we call the crown of the tooth, or the part of the tooth that we see above the gum line, and the root of the tooth. When we start having gum recession and parts of the root are exposed, then those parts of the tooth that are exposed are now predisposed and susceptible to getting decay. Root decay is something a little bit more difficult to treat, not impossible, but a little bit more difficult to treat, also because patients have difficulty reaching those surfaces to clean, to take care of on a daily basis. And those root surfaces are more prone to decay because we no longer have enamel on those surfaces. So it is important to monitor. It's important to have good daily routine, because recurrent tooth decay, recurrent around the edges of fillings, recurrent along the cervical lines or along the root surface, recurrent along a bridge that might be in place, or even the root surfaces of the teeth. And we know that recurrent decay affects the elderly. Remember, we talked about xerostomia. Dr. Smith brought it up. When we talk about xerostomia or dry mouth combined with recession of the gums, then the predisposition or the risk for this patient to have root decay is very, very high. So we need to help this patient with some chemicals, maybe with some medications that can be used to treat those root surfaces to make them a little bit better protected to fight decay. And it's very important that we have proper examination before we do a recommendation for products and preventives. So remember that anytime we are dealing with periodontal disease or gum disease, we are dealing with tooth or surrounding tooth substance loss. For example, there might be loss of the bone, there might be loss of that gum height around the tooth. So not only periodontal disease or gum disease will put the tooth at risk of being lost, but also we may have the stability of the tooth that's compromised. You know, if advanced periodontal disease or periodontal disease is not treated, we will see loosening or mobility of the teeth happening. And what happens with that is that the patient may lose his or her ability to chew properly, or they may develop pain. So if one side of the mouth hurts, they're only going to chew with a few teeth on the other side. So it may affect their ability to wear a partial or wear a prosthetic that they had, because the teeth aren't firm and stable in place. Periodontal or gum disease also has the ability to just affect the natural teeth and make them hurt as a result of the disease. And it eventually can affect the systemic health of this patient, the overall health of this patient. So we know that untreated gum disease or periodontal disease can actually result in some respiratory problems or lung diseases. We know that poorly managed or unhealthy periodontium or gum tissue can cause cardiovascular problems. We also know that with the presence of gum disease, there is a heavy load of bacteria in the mouth that we don't expect to be there. So it's important to treat to decrease that bacterial load. With periodontal disease, we also have a greater risk for osteoporotic events. If we have loss of the teeth, loss of function of the teeth, we also tend to have loss of bone around the jaws as well. And even arthritic disorders might be connected, are linked to periodontal or gum disease. These are inflammatory processes. When we look at arthritis, and if we understand how arthritis happens, and that it is highly linked with an inflammatory process in the joints, well, periodontal disease is also associated with an inflammatory process. And we need to make sure that we can control all of the contributing factors to inflammation or even infection that may come from the mouth. We even have some accounts from the medical literature linking gum disease or periodontal disease with Alzheimer's or certain types of dementia. So it is basically to tell you that what we have here is a connection of the oral cavity with the rest of the body. And we are, surveillance and physicians of the mouth. We are particularly concerned about this particular age group who may develop dry mouth, may develop side effects or subsequent effects, what we call undesirable effects of some medications or even diseases or illnesses that they're dealing with. On the little slide here on the right side, I'm going to talk about dry mouth in a minute, but what I would like for you to see is that we have on this little picture, we have gum recessed, we have buildup of tartar or calculus around the teeth. We're seeing where bone is definitely lost in this mouth. And what we're seeing here that you may not be able to appraise or assess is that this patient has a very dry mouth. So when we have dry mouth, not only it feels uncomfortable, but everything else that we talked about, the decay or caries, the periodontal or gum disease, the mucosal changes, all of that is aggravated. All of that is accentuated. So when we have dryness of the mouth, it affects the lips. It affects the tissue of the tongue. In fact, we see many patients who come to us and say, it feels like my tongue is burning, feels like something is on fire all the time. So it may be an effect of dry mouth. It may be that the dry mouth is linked to a problem or a disease of salivary glands or saliva producing glands. We also see an increase in the presence of thrush or fungal infections that are associated or may be presented, that are associated with dry mouth. And obviously an increase in the presence of tooth decay and buildup of tartar around the teeth. We also know that dry mouth causes gum irritation. Saliva in our mouths the saliva is a wonderful lubricant. When we think about individuals developing dry eyes and they feel that they can't close their lids because when they move their lids or they move the eyeballs, everything feels scratchy. Well, if we don't have saliva, the gum and the mucosal tissue, it feels like it's scratchy all the time. So we're eating and we may not be able to have crunchy foods. We may not be able to experience certain foods because we cannot chew them properly, and we don't have enough saliva to lubricate and mix in with the food particles to swallow and enjoy. We also lose the ability to taste properly. Our mouth is designed to have something wet in it, and if we don't have enough saliva, we've got to counteract for that. Water is the best juice. Water is the best lubricant if we don't have the saliva, and there are other products that can be used as well. Patients also have difficulty wearing their prosthetics, and by that I mean they have difficulty wearing the dentures if they're missing teeth. They have difficulty, for example, wearing a partial if they wear that, if they will have a retainer, anything that goes in the mouth, because it feels like it's going to scratch some more and it's going to hurt them. Many times individuals who have a dry mouth what do they have? They have dryness in the esophagus. They have dryness in that pipe that takes the food down to the stomach. So it makes it difficult to swallow. We'll have a patient who will turn to us and say, yeah, I can only have liquidy foods or only have something that's in a shake form because I have a hard time chewing my food. So all of this comes with the event of dry mouth. And we know how present and how prevalent that is. We have a significant portion of this population that is affected by dry mouth, either because of the medications that they're taking or because of ailments and diseases that can affect salivary production and the salivary glands. Another issue that, I don't have it on the slide, but it's an observation among, friends and relatives. As we age, we may tend to drink less. There are several individuals, several patients, several folks in this group who will say, well, I don't drink as much because that means I have to stop. I may take more bathroom breaks. I just don't feel good when I drink water. I can't taste it. My mouth feels different. So we need to make sure that dry mouth can be counteracted, can be treated as a side effect, whether it's a side effect of medications or a side effect of just diseases and changes in the body. Other problems that we commonly see. We see many times failing restorations. And in one of my first slides, I brought up the fact that our sensation of the teeth changes over time. So we may not be as sensitive. I may have a fractured filling in my tooth that would have caused problems when I was 20 years old. But because now I'm 60 or 70, my teeth don't feel the same. So I have no sensation. And that failed restoration may actually progress and I may have a problem. Now becomes a big problem because I don't have any symptoms about that or related to that. We also see other problems with dentures or partials not fitting properly. Is this the fault of the patient? No, many times what we see with the poorly fitting or ill-fitting partials or dentures is that if they're worn for an excessive number of years, they stop fitting. It would be the same thing as my still trying to wear a pair of shoes that I bought 10 years ago that I wear every day. Those shoes are not going to be in good shape. They're not going to fit me properly. They may be very comfortable, but they may not protect my feet to the same extent. They may be worn. They may be causing some soreness in one spot or another. So poorly fitting dentures and partials need to be addressed. And sometimes what we have to do is a repair. Sometimes what we do is to refurbish or readdress issues that can be just localized to one area or another. But it's a mistake to allow poorly fitting dentures or partials to continue to function for that patient, because so many times if there are natural teeth there, they'll end up suffering from the ill-fitting partial. And I do not mean to make an analogy of dentures or partials and compare them to shoes, but sometimes my comfortable shoes feel good to me, but they may not be the best shoes I wear if I'm going out on a rainy day or a rough terrain, right? So what do we see here? We see a partial that is actually has some issues, not just with fitting and wear and loss of some of the teeth. This one, I wish I'll do a little correction in my display here. This partial has been split and was mended, and the fitting of it is no longer the same. So it can actually cause some problems for the patient himself or herself. Very common occurrence is thrush or candidiasis. When we lose the saliva, we lose that natural lubricant, and we may have now the occurrence of fungal infections occurring, and especially if dentures are not well fit, and we have the opportunity for bacteria and other organisms to start growing onto the partial or the dentures. So it's important that we inspect those, we treat them, we clean them properly, and then we treat the patient's mouth if that's the case. And this is what one of the presentations of oral candidiasis. We see that whitening of the tongue, a lot of redness of the gum tissue, a lot of redness of mucosal area, and there are different ways for it to present itself. Another common occurrence is that cracking on the corners of the mouth. And that's what we see here, cracking of the lips and cracking in the corners of the mouth. And we call that angular cheilitis. And what happens here is that the patient may struggle with this area being constantly irritated. Saliva may build up here, or they may get an infection that comes back and recurs and aggravates them, and they feel sore. And, we want to put lipstick on and it never looks right. I'm kidding about that one. And tooth wear. That's just to illustrate that tooth wear can happen to our natural teeth, and it can happen to the artificial teeth that we may have on prosthetics, may have on our partials. So bruxing, clenching, grinding, all of that needs to be addressed, because both the natural dentition and also the teeth on the prosthetics that someone may wear will be altered and will be affected by it. And here's a typical example of someone who grinds at night and is unaware and cannot control that habit. But the spouse brings this patient in saying, look, so-and-so wakes me up in the middle of the night and I hear the gnashing of the teeth and the grinding and all that awful noise. And what we see here is that the enamel is chipping and wearing, and we see a lot of the tooth structure that's missing. So we need to have action here to preserve these teeth, because we want to get some function out of them for years to come. So what else do we have? We have problems of the mouth that cannot be diagnosed without proper radiographs. So remember that when we have something that goes unnoticed and without symptoms, there's a propensity and the potential for that to continue to evolve without the patient being aware, without anyone around them being aware. You may be the caretaker, you may be the sibling taking care of someone, the child, the significant other. So preventing and actually detecting problems early has major advantages. I always tell my patients, if I take care of a small cavity, it's so much easier on the patient and simpler to address. It's a single appointment. It takes less time. It costs less because we're taking care of something small. If a cavity progresses and now it turns into a big cavity and we need a root canal, or we need a crown, or we need to do something else for this tooth, it takes longer, it takes more appointment, it takes more time, it's more costly. And not only that, it's a task for the patient as well. Have to keep that patient in the chair longer. It's harder for the caregiver to have to do multiple trips and all that. So I have on these x-rays, you've seen this x-ray here with some examples of what cavities look like on the x-ray that we may not be able to detect by just looking in the mouth. On this particular x-ray, we see the teeth here, the teeth and the roots, and there is a wisdom tooth that's still up there, and on another wisdom tooth that's buried down here in the jaw. Well, not only that, we actually have a big lesion that's an undesirable lesion. This is either a cyst or a tumor in the jaw that has actually grown and developed itself around that wisdom tooth. If we don't have this x-ray, I would never be able to see that lesion in there. And this person had to go see a head and neck oral surgeon. On this next x-ray, what we see is a tooth that had, at one point in time, this person had bumped this tooth. And what we have here at the apex, or the end of that root, there is a cyst. If I do not take this radiograph, I would not know what's going on and how I have to treat this patient. We also use x-rays to check on existing fillings, existing crowns. In this case here, there are crowns, there are root canal treatments, there are actually implants down here. If you have heard of implant services and implant treatments, we take radiographs, we take x-rays to monitor to make sure that implants are healthy too. We take care of x-rays, we take them and we examine the teeth because there might be something called recurrent decay that now used to not exist, but is along the edges of an existing filling. So many reasons to take x-rays and many reasons to have a look at that oral cavity. We bring in this x-ray not trying to get anyone, grossed out or eked out about what we do. We have examples of what thrush looks like. We have examples of what a benign ulcer would look like right here. But we never know the difference between what this redness here might be and what that redness there might be. It's very important that we examine the mouth because some of these lesions will and can develop into oral cancers. So super important to monitor, important that if you see in your loved one, if you see that something is developing that wasn't there, it does not matter that it does not hurt. Usually lesions that do not reflect pain can be lesions that might be aggressive and might mean that there's something not so positive going on and needs to be checked. So with that, I leave you with some resources. And I know that this presentation is being recorded, and we may not have all who will assist and listen and look at the presentation ask us questions, but I will be glad to take any questions that you may have for us.
Our information as well, but we did have a question here that came through. It says, are there any mobile dental clinics or in-home health type options for dental care specifically available in the central Alabama region? If not, are there any plans underway to seek grants and other providers for such options? And that's a really good question. I've seen, different special clinics that'll pop up, depending on what the initiative is. But that does seem like a pretty good question. Are you guys aware of anything, even if it's, during certain times of the year? Does UAB have anything like that? And if not, that might be a good plan to kind of consider for the future.
Well, this is a great question, and I know that Dr. Smith can add to this here too, because he's had so many years of working with the public health network of clinics as well, and they serve different age groups. But I would like to add that as an agreement, an affiliation that UAB has with the Alabama Department of Senior Services, we will be doing screenings in different parts of the state. We're so glad to know that some of the senior centers are fully reopened, and we hope to take that opportunity this fall. We will be coordinating, and M4A actually helps us with that coordination of screenings in some of these facilities. Now, that does not mean that we can take a mobile clinic with us, but we will be glad to be the resource there to say, okay, there's a problem here. Let's go ahead and try and find a dental home for this particular individual, for this patient, for this loved one. We will be doing screenings with some of our dental students. So we will be coming as faculty, as the dentists with the degrees, and some of our trainees to help us in the process. And I would love to tell you that, we have these mobile dental homes that actually move around the state, but I'm not aware of a structure that exists right now. And the difficulty with that is allowing the coordination of services. We will in the future, hopefully, enhance our ability to provide consultations over time. But at the present time, our state has limitations, even if we provide, for example, telehealth consultations. So there are some things that we would like to do, but we have to abide by the law in the state. And we are limited as to the type of consultation that we can provide, for example, in a telehealth call or a teledentistry call. We hope to reach out and branch out and go to more centers and more homes around the state, not only this year, but in the years to come. So I'm open to suggestions from this group. In fact, if you say, look, I live in a community where we don't have a lot of dentists, or we have a couple of dentists, I would love to see that and hear about that. Dr. Smith and I are willing to not only connect with that community, we would love to place a graduate in your community. And we feel that if we are able to bring our students with us and do some of this community assessment appraisal of the needs, that we hopefully will entice someone to practice in those areas.
That's wonderful. What's the best way? And Dr. Smith, I'm going to give you a couple of seconds too to answer if you had anything you wanted to add to that. But what's the best way, coming off of what you were just saying, Dr. Mazur, what's the best way to contact you guys? Because that does sound like a really awesome way to, like you said, kind of shed guidance, get feedback from those areas. And really, I mean, the best way to plan for the future is getting feedback from those communities that might have difficulty. So what's the best way to contact you guys directly to be able to set something like that up?
Absolutely. I would suggest that if we're contacted via email, and if you work with a group, you work with a community, a subgroup in your area, please collect that information for us. And if we're able to coordinate something to help serve you, to help take care of those individuals in your community, we're more than glad to do that. We have reserved some times in our academic calendar to actually reach out, and some of those times are already booked, but some are not. So reach out to us via email, and Jeremy and Jennifer, we'll be glad to share that, and maybe you can actually utilize M4A to disseminate that information for us. Dr. Smith, I don't know if you want to suggest a different venue or different means too.
No, everything you said is perfect. That all sounds like an excellent plan.
Well, I'm happy to hear that you guys. I mean, we have such a large organization, and UAB is no different. But with our agency, as you see there on the screen, we're the Middle Alabama Area Agency on Aging, or M4A. We specifically cover 5 counties, 6 including Jefferson County for our senior employment program. But we have an enormous amount of different programs that we host within our own office, and it's great to hear because there's actually 13 of our agencies with different names kind of scattered throughout the state that cover each county in the state of Alabama. And the Department of Senior Services is actually the parent agency that we report to. So it's great to hear that initiative is rolling. Like you said, some of the centers are open back up, or a lot of the centers are open back up for now. But that's amazing that's kind of in the works, because who knew that that oral health was this important. I mean, I myself, I feel like every time we do one of these coffee breaks, the presenters, especially as they pertain to health, the presenters are usually talking directly to me, because I'm the type of person, I'm in my 30s, but I'm the type of person who hates going to the doctor. I hate going to the dentist even more. And this has really been, kind of an eye-opening experience to me, because, who knew it could lead to so many other problems. And for me personally, now is a good time to start thinking about that stuff and really trying to get on the forefront. So we really appreciate you guys coming on. Again, if you're joining this presentation live, towards the end, we are recording this, so we will have the information, kind of cleaned up a bit, put it on our YouTube channel as well as on our social media feeds. We'll also have it in our newsletters. If you have any questions after this presentation, feel free to let us know, either by putting that under the comment section on our Facebook feed or YouTube channel, as well as, respond or get in contact with our office at M4A. There's our contact information on the screen. We are in Alabaster, but you can also reach us by phone and online. And looks like we just had a comment. Thank you. Great information. So appreciate you guys coming on. And we will, again, just as a reminder, coffee break is once a month. We typically aim for the last Wednesday. I believe this is the correct date, August 25th, from 1 to 2 p.m. We did go over just a little bit this month, but man, this information's been great. So we appreciate you guys taking the time, because we know it's something that's really probably not covered enough. So, but next month, we're going to be changing gears just a little bit. We're going to be looking into diabetes awareness. We don't have the speakers nailed down yet, but we will have that information soon, and we'll be, sponsoring it and putting it on the social media and in our newsletters and kind of broadcasting that. So if you have any suggestions that for the future that you think might be good conversations to have, make sure you send an email to panda@m4a.org. That would be really the best way to kind of get a new topic discussed. And we definitely want to make sure that we get feedback from you guys. Just like with anything else, we want to make sure we get feedback as well on our coffee break series so that the content that we're bringing is beneficial to our caregivers. So with that, we're going to close our meeting out. Look to have this up on our social media feed probably within the next week. And again, if you have any questions, make sure you reach out to us. You can also send your questions to panda@m4a.org. But we thank you so much for joining us. Thank you again to our panelists for joining us. And we look forward to talking with everyone next month.
Thank you, Jeremy. Thank you for the opportunity to be here.
Thank you guys so much.